He'll be speaking on one of the most important thing for any refractive surgeon, Pentacam interpretation for the Lasik eligibility. How many of you have the Pentacam? Or I would say any tomographer? Okay, so which one you are using, sir? Cirrus. And madam, you behind? Cirrus only. Okay.
Good morning, everybody. So I'm going to go to a little bit of basic evaluation as far as the Pentacam is concerned. And I think everybody will agree with me that it's the most widely used, widely studied, and widely accepted modality of pre-Lasik assessment. And it's almost become a gold standard. You know, you need to have a Pentacam fit patient to actually go for the Lasik. Now, how do you evaluate Pentacam in your busy clinic? So you may have a Pentacam, or you may order it. Yeah, sorry about that. Yeah. So how do you see this? So if you're getting it done from outside or even from your center in a busy clinic, you want these 4 reports with you to make a assessment. The 4-map refractive, Bell-in-M ratio display, topometric map, and fast screening report. And you essentially would like to see these 6 points when you are evaluating a Pentacam. So let's see one by one. So the first is a 4-map refractive, and the first thing that you will see is the quality score. So if it's okay, you would proceed to evaluate it. If it shows yellow, that means there are data gaps, you need to repeat the procedure. So that's the first thing that you will do. And the next important thing is pachymetric map. Pachymetric map essentially will give you 2 things. It will give you a map, which will basically give you point-wise representation of the corneal thickness. And on the left side, you will get what is the dimensions of the 3 important parameters, that is the thinnest local, pachy apex, and pachy at the central most point of the pupil. So here the important point is the thinnest local. So if you have a thinnest local of less than 417, then obviously this patient would not proceed with a refractive surgery. And if it's between 470 to 500, we can consider a PRK if the other parameters are normal. The other thing that we will know is the difference between pachy apex and thinnest local. It should be less than 10 microns. And the next important point is noting the vertical displacement of the thinnest local. And if it is more than 0.5, as can be seen from this thing, you definitely this will contribute a red flag. The other thing that you can see is the difference between superior and inferior corneal thickness. If it is more than 30, then it's a red flag. So these are in short the pointers which will tell you what abnormalities can happen, which you need to look for. Elevation is the most important graph in Pentacam, and basically what it does is basically it gives you elevation values at the anterior corneal surface and then the posterior corneal surface. And how does it do it? It basically, the machine takes out data from the 8 millimeter diameter and it makes up a best fit sphere, which is then put across the anterior surface. The areas which are above the best fit sphere are basically shown as steep areas or warm colors, giving a positive sign, and the areas which are below are given as negative or flat. So just look at this. So here is the anterior, the front elevation, and this is the back elevation. So you can see clearly there is +5, +7. So these are the areas which are above the reference surface, and on the back side you have around +12. So any anterior elevation above 8, posterior elevation above 17, and any point where the anterior posterior elevation difference is more than 5, it's significant. And very important is to look for any isolated islands. You can clearly see there is an isolated island. This also should be a pointer that something wrong is happening. Another important parameter which has come off late is the thinnest point. So what you see is a circle here, the thinnest elevation at that point on the front and the back. If anything is above 5 on the front and above 12 on the back, then this is a significant. Next is the sagittal curvature. I think we all are aware of sagittal curvature, but what parameters we need to look at are these. So you have the flat K, because you want to know the flat K as to how much we can do the correction. So every 1 diopter of myopia, you are basically inducing a 0.8 K fattening. We don't want to go below 34. K2 will give you steep K, so basically you don't want to go beyond 49, 50. Then you have mean K, because anything below 40 will have a risk of free cap, more than 46 will have a risk of buttonhole. And K max, anything beyond 48 is a red flag. The difference between 2 K max between the two eyes should be less than 2 diopters, and difference between K max and the steep K in the same eye should be less than 1 diopter. So this is another important point wherein you basically get color representation of the sagittal curvature. IS difference of it should be less than 1.5, and SI difference should be less than 2.5. It also gives you shape. These are symmetrical shapes, or you can have asymmetrical shapes, which actually can show pointers towards the different types of ectasias. Like here you see a pellucid marginal degeneration, here you see a keratoconus. Then you need to look at the skewing in case of astigmatic bow tie astigmatism. So if there is a skewing, the tilting of one of the lobes, if it is more than 22 degrees, as can be seen in this thing, then it is abnormal. So these are the important points that you have to remember when you're looking at the sagittal curvature. And the fifth point is the Bellin-Ambroisio map, which basically should be viewed in these 4 points. So we'll go one by one. So basically, Bellin-Ambroisio ectasia map creates a new best fit sphere by excluding 3.5 to 4 millimeter of area around the thinnest point on the cornea. And what it does, it creates a new reference surface which is flatter than the original reference surface. As a result, the ectatic areas get enhanced. So if you can see clearly that we compare this to this, this has become flatter and this area has got exposed more. So how do you apply it clinically? So this is the patient's original elevations. Now when you apply the Bellin-Ambroisio new reference surface, you can see clearly that the ectasia has got enhanced. Now what is the difference between these two? We get it in the difference map. So anything beyond 7 microns in the right on the anterior and beyond 16 microns in the posterior becomes significant. So next is the thickness profile map. Basically, you have about 22 concentric circles which are drawn across the thinnest point on the cornea, and the pachymetric measurements is done from the thinnest point to the outermost version, and basically you get a graph. So you get 3 dashed lines. The middle line is basically the normal population's value, and the the superior and inferior basically shows 95% confidence interval. The red line is patient's values. So usually it should fall between these 2 lines and it should follow the curve. And the percentage thickness index increase is essentially the same thing in the form of a percentage. So here you can see an abnormal shape where there is a quick slope where it dips before the 6 millimeter zone. So definitely there is a fast thinning that is happening here. The point which I was telling you, the thinnest point elevation, this values you can get it from here. Then there is something called as Specky progression index, how fast the progression happens. There is an index to that. Anything beyond 1.1 is abnormal. Then there is something called as ART max, which is also an important parameter which is there. But most important is these 5 deviations which are actually taken out from all the values that we have just discussed. And it will label it as white if it is less than 1.6 standard deviation from the normal population. It labels it as yellow if it is 1.6, beyond 1.6 to 2.6, and red if it is more than 2.6. But the most important here is the final D, which is a global parameter which will encompass all the individual parameters, and the guidelines which Dr. Bellin, who is the inventor of this thing, is clearly mentioned here. So try to stick to these guidelines. If you are doing Lasik, of course, if you are doing PRK, the guidelines are a little more liberal. And the last is basically topometric map, wherein you look for this indices, and you don't have to remember the values. The machine itself will flag it as white, yellow, or red. And this is a fast screening report. I would suggest that this should be seen at the last, because by the time you have evaluated all these parameters, this gives you a very good look. The horizontal bar is basically the distribution of the normal population, and it is at one standard deviation, 2 standard deviation. So where does the patient's value sit in that graph is what it gives you. So this is how you go ahead and do a systematic evaluation of a Pentacam, right from the first map to the last map. And believe me, it takes about 5 to 7 minutes to go through all this in a systematic way. It's very difficult. Then it's very unlikely that you will miss anything abnormal out of this evaluation. So thank you.
Excellent presentation. In the positive time, you have tried to cover almost all the topics. But one thing I would like to add up, that Pentacam still is not a perfect unit. Whatever indices you showed, like the pachymetric progression index is there, whenever you say the curve dips, they all have been taken account by having the Western data in mind. So suppose you have everything normal, you have a normal curvature, and suppose your pachymetry is around 500, and if that curve is typical, it doesn't beat that, the patient is abnormal. So you can also do it. So what is important here, like you mentioned, is to see the shape in the axial curve. That is the first and foremost sign where you can quickly pick up whether there's a skewing or no, whether there is inferior stiffening or no, whether there is a skewing of more than 30 degree or no. I think those play important factor rather than believing in all these indices. Again, the ART max and all, they have been all made using these Western data. So don't follow them blindly. That is my take-home message to all of you.
Western data is there, but we have Indian data also from Dr. Shetty's group. It has been
Yeah,
published in
Yeah,
AGO.
just last 2 weeks before we had Dr. Shetty, we were blessed to have him, and he himself suggested that you just don't follow it blindly. Instead, you just see the patient as a whole. And another important thing is when you have this 4-map refractive and we have this thinnest location, you click on that and you draw a square over there. And all those 4 points are coinciding, then yes, definitely your patient is at trouble. But what you said is right. Whenever you're following in your early days, yes, you have to follow this. But once you are above that, you need to see the patient as a whole rather than blindly believing in those indices. Any views of you, Dr. Manpreet?
Yeah, of course, I think always make a habit of correlating clinically. And nowadays, we have newer modalities. We are taking biomechanics into account. We have Corvus, etc. So in toto, I think you can, and it's better to be safe than sorry. The borderline cases, rather avoid than think if you can go ahead with surgery in that or not.
And I think Pentacam also gives you a lot of false positive. Suppose the patient's white to white is less than 11.4. So if it is between 10.9 and 11.4, then you are going to end up having a lot of these elevation points on the balloon as well. So again, you have to keep in close eye whenever you take a Pentacam reading. You have to keep in close eye over the white to white as well. Any other questions? Yes, sir.
I think for a soft contact lens, 1 week to 10 days is enough. But if it's an RGP, probably 2 to 3 weeks would be an ideal time for the corneal shape to come back.
Correct. And suppose you are feeling that the patient is having slightly dry eyes, then once you ask the patient to remove the contact lenses and start them on the lubricants, and it works well in case of the soft contact lenses. Any other view?
Yeah, I think we follow the same dictum, a week to 10 days and 2 to 3 weeks for RGP.
A lot of patients come for screening on a day where they just want contact lenses.
Yeah.
So I do kind of screen them on that day.
True,
If it's
true.
absolutely normal, I schedule them for surgery, but I do repeat the Pentacam on the day of surgery to make
Correct,
sure
correct.
everything is normal.
I think that's what we all do. And that is the right way to go forward. Do not operate them on the same day. That is a take-home message. You should wait.
Plus also if you tell them we are not screening you today, you come back after.
Yeah.
They won't come back.
Yeah.
Yeah.
Dr. Anand, you had question? Correct. Yes.
70% and sensitive around by 90%. So we
Correct.
should be very cautious.
Yes.
Slightly
So the
overestimate.
question is whether it differentiates normal from keratoconus or normal from subclinical keratoconus. So from differentiation from normal to keratoconus, it's very clear. It differentiates very nicely. The problem is in the
Middle
gray
one.
zone,
I
in
think
the
that's
gray
the
zone.
one
So
we
that's
all
where
are
you
having
need a
trouble.
combination of those parameters. One parameter doesn't work out well. You need a combination.
Yeah, so nowadays you need this epithelial mapping, I think, to, as rightly mentioned by Dr. Anand, you do have a lot of false positives with the Pentacam. So I think epithelial mapping and stromal elevation is the way to go forward. But they are very costly machines, I guess. The one is made by the CSO MS39 and it costs almost 90 lakhs with the taxes. So I think we all may not be able to afford it, but what we can do, we can have this thing in mind. All those shapes like Dr. Tushar had showed to us, whether this is a normal bow tie, this is a symmetry bow tie, asymmetry bow tie, superior skewing, inferior skewing. That is the first image you should have in your mind whenever you're trying to go for the refractive surgery.